Good afternoon. Welcome to Grand Rounds today. Please remember to sign the attendance record at the back of the auditorium, and also please remember to fill out and return the program evaluations, and if you would give the CME committee any ideas in regards to future topics or future speakers, we'd be quite interested. Today, I have the pleasure of introducing Dr. Suresh Chari. Dr. Chari is a professor of medicine at the Mayo Clinic College of Medicine, and he's a consultant in the Division of Gastroenterology and is the head of the Pancreas Interest Group in the Department of Gastroenterology and Hepatology. He's been extensively published and has a special interest and expertise in the early diagnosis of pancreatic cancer. The CME committee is particularly pleased that he was able to accept our invitation to drive down today and update us on pancreatic diseases. And please join me in welcoming Dr. Chari.
Thank you so much. Thank you so much for having me here. It's a pleasure to talk to you about something which is close to my heart, that is pancreatic diseases. I've kept the talk deliberately somewhat general for the diverse audience that's here. I'm happy to take any questions after the talk. I'll briefly go over some of the common diagnoses that we encounter in our pancreas clinic, which includes acute pancreatitis, chronic pancreatitis, and something that is growing fairly rapidly, that is pancreatic cysts, pancreatic cancer, and briefly touch upon a rare diagnosis, autoimmune pancreatitis. I will also go over some of the things that we see which are labeled as pancreatic diseases but which are not, including sphincter dysfunction, pancreatic pain, macroamylolemia, and abnormal fecal elastase. Actually, fecal chymotrypsin is not usually performed in this country. There's lots of patients we see where there's an overcall on the CT, elevated serum IgG4, abnormal EUS in an asymptomatic patient. Number of things that can mislead you into thinking a patient has pancreatic disease when they don't have it. Let's start with what is acute pancreatitis, and the American College of Gastroenterology has some criteria for when somebody should be called as having acute pancreatitis. And the clinical diagnosis of this requires 2 out of 3 to be met. Severe abdominal pain radiating to the back. This is somewhat nebulous. A lot of patients have abdominal pain, and so all it says is pancreatic pain in the guidelines, and unfortunately that means anybody with epigastric pain. Amylase and lipase more than equal to 3 times the upper limit of normal. This is something that we believe is important. And finally, cross-sectional imaging evidence of pancreatitis, which is usually CT or MR. And while pancreatitis can occur in patients who don't meet these criteria, if you consistently dilute these criteria, you are at risk for overdiagnosis of pancreatitis. And this often happens when a patient with abdominal pain is admitted to the hospital and they have an amylase which is slightly above normal, and your immediate tendency, oh, this must be pancreatitis, but the patient doesn't meet criteria. And you do a CT and that is also normal, but patient is left with the diagnosis of pancreatitis, and just because you don't have another diagnosis, you'll label the patient as having pancreatitis. It's not in the best interest of the patient to have that label. So we have a hard time sometimes explaining to the patient that you never really met criteria for pancreatitis despite having repeated admissions to hospital for quote-unquote pancreatitis. So we believe that, as far as possible, we should adhere to these criteria to avoid overdiagnosis of pancreatitis. Lots of bad things are done to the patient when you have pancreatitis. If you have pancreatitis, it's right, but in the absence of pancreatitis, removing the gallbladder, cutting sphincter, stenting the pancreatic duct, all this is inappropriate. And all this happens because the patient got strongly labeled as pancreatitis. And the etiology of pancreatitis, these still remain the same. Gallstones and alcohol probably account for 70% of all cases. Idiopathic is now mostly considered, for many of those patients have some kind of genetic mutation which is not familial and therefore apparently looks sporadic, but they have a genetic mutation. Then there is familial pancreatitis, where there is a mutation which explains the autosomal dominant nature of the disease. Metabolic diseases, hypercalcemia and hypertriglyceridemia are easy to check for, but not very common. Drugs are often blamed for pancreatitis, but are harder to prove, and I'll go through some of these diagnoses here. So the best predictor of gallstone pancreatitis is actually the labs you draw on day one of admission to the hospital. Whenever a patient comes to me, I always ask for the labs on day one of admission because that's the best predictor whether the pancreatitis was due to gallstones. And an AST/ALT of more than 3 times the upper limit normal on day one has a high specificity for gallstone pancreatitis. The bilirubin and the alkaline phosphatase take longer to go up, and if the stone passes, they may never go up. So it's the AST and ALT that are the best predictors there. In the absence of this, the diagnosis is not definitive. And we did a study here to look at some of these issues, and we looked at the patients who had a cholecystectomy in Olmsted County for pancreatitis. And then we looked at what was the recurrence rates of pancreatitis based on these 4 patterns. That is, there was gallstones in the gallbladder and a typical rise of liver tests on day 1. Or they did not have gallstones in the gallbladder but had a very typical elevation of AST and ALT. Or they had gallstones in the gallbladder but no elevation of LFTs. And finally, they neither had gallstones nor had elevation of liver tests. And we tried to understand what the recurrence rates were. The understanding is that if the recurrence rates are very low, the pancreatitis was due to gallstones. And if your recurrence rates are high, then the pancreatitis was not due to gallstones in these 4 conditions. So if you look at the first group, you see there's a recurrence rate of about 5%. And this is fairly typical because you have some stones left in the common bile duct despite all your search, and that can come back and cause pancreatitis at a later date, but 5% is accepted as a recurrence rate. So this is typical gallstone pancreatitis. You take the gallbladder out, the pancreatitis should not recur. What was interesting to see is that if you have typical elevations on liver tests but don't have gallstones, you still have a very low recurrence rate after cholecystectomy. So to me, this taught me that day 1 liver tests are very useful in identifying who has gallstone pancreatitis. If you have gallstones in the gallbladder and you have pancreatitis, the tendency is to remove the gallbladder because what else? You don't have any other etiology, so remove the gallbladder. But it is clear that this is not all entirely explained by gallstones, and this could be an innocent bystander. And so you need to explain to the patient that, yes, it's okay to remove the gallbladder, but this doesn't completely exclude the possibility of the pancreatitis coming back again. And finally, this group, which does not have stones or LFT abnormalities, has a very high recurrence rate, suggesting that this is truly idiopathic, and the removal of the gallbladder is not going to change the course of the disease. So this was very helpful to understand how to predict and what to do in this setting. So there is, of course, a set of patients with gallstone pancreatitis who need urgent ERCP. Gallstone pancreatitis is caused by migration of gallstones from the gallbladder into the common bile duct, and as it exits the ampulla, it obstructs the pancreatic duct transiently and causes pancreatitis. So if you do an ERCP in a patient with on day 1, few hours of the onset of the attack, you'll find gallstones in almost everybody because that's what the cause of the pancreatitis is. And therefore there is that, but majority of those gallstones will pass. 85% of those gallstones will pass. So question is, when does the patient need urgent ERCP? And the 2 indications that have stood the test of time are persistent biliary obstruction and cholangitis. And how do you know a person has persistent biliary obstruction? If the patient gets admitted at 6 p.m. with abnormal liver tests and pancreatitis, you repeat the liver tests 8 to 12 hours later. And if they're rising, that means the stone is impacted. If they're falling, that means the stone has passed. So I often have a paired liver test and try and see which way the patient is going. The patient has a dilated bile duct that generally suggests obstruction has been there for some time. If the patient comes within hours of the pancreatitis, the bile duct may not be dilated, but if it's been persistently obstructed for 8, 10, 12 hours, you can start to see a dilatation of the common bile duct. Of course, the patient has cholangitis, typical cholangitis, that would be an indication for urgent ERCP because there's an obstructed duct with infection. And all patients with gallstone pancreatitis need cholecystectomy soon because there are very high recurrence rates at 6 weeks if the cholecystectomy is not performed. The recommendations say take the gallbladder out in the same admission, but I would say get the surgeon to see the patient and get a date for surgery within the next week or two, the patient has gallstone pancreatitis. The only subjects in whom it can be delayed is if you've done a sphincterotomy. There's a very good evidence to show that a sphincterotomy protects against another attack of pancreatitis in over 90% of the time. But it won't protect against biliary colic and cholecystitis, but it'll protect against another attack of pancreatitis. And in patients who are sick, patients who are elderly, patients who have got a very severe pancreatitis, this is one way to bide time in terms of doing a sphincterotomy and delaying the surgery to later. Now let's look at alcoholic pancreatitis. Again, there is a tendency to say patient is drinking, patient has got pancreatitis and alcoholic pancreatitis. But usually the patient has been drinking steadily for 3 to 5 years. It's not something that happens after an acute alcohol intoxication. A freshman in college who's never drank before gets drunk on his or her first encounter with alcohol, generally will not get alcoholic pancreatitis. There is large studies, autopsy studies, looking at patients who died of pancreatitis, and very, very few patients had acute alcohol intoxication without prior history of alcohol use. So it generally requires some prolonged alcohol use before you get pancreatitis. And majority, over 90% of them smoke. So now people are wondering whether smoking is more important than alcohol, but it's a combination of the two which is important to cause alcoholic pancreatitis. It does account for 40% of patients with acute, and not everybody who has acute alcoholic pancreatitis goes on to develop chronic pancreatitis. So abstinence is very useful in this setting to prevent future attacks. And of course, it can also lead to chronic pancreatitis in a subset of patients. The metabolic causes are easy to look for. High calcium needs to be repeated for confirmation. Isolated high calcium is never enough to make a diagnosis, but if you repeat it and it's high calcium, hypercalcemia has been associated with pancreatitis. But the flip side is that majority of patients with hypercalcemia will not get pancreatitis. So we still don't know why some people get it. But if you have hypercalcemia and you have pancreatitis, it's generally appropriate to correct that hypercalcemia. But remember that it's the other way around. It's not necessarily true. Same thing with high triglycerides. Generally, it is said that it should be more than 1,000 milligrams per deciliter for you to blame the hypertriglyceridemia for the pancreatitis. And of course, one would like to see persistent elevation in the absence of pancreatitis to explain. So pancreatitis can cause hypertriglyceridemia by itself. Alcohol can cause hypertriglyceridemia. If you have mild elevations in triglycerides, they can go higher. So all of these things come with some caveats, but in many patients it's quite clear that even between episodes their triglyceride levels are very high, and there it's appropriate to think of hypertriglyceridemia as a cause of pancreatitis, and controlling hypertriglyceridemia is the key to preventing future episodes of pancreatitis. So these two are useful in that if you correct the metabolic problem, the pancreatitis will also go away. Genetic causes as we start to explore these patients with pancreatitis, we are finding more and more cases of genetic mutations. Majority of them play a minor role in pancreatitis. It's very clear, if you took alcoholics, if you took 100 patients who are hardcore alcoholics, 5 will get pancreatitis. The question is, why those 5? So we believe that most pancreatitis is a combination of genetic predisposition and environmental insult. And so many of these mutations are seen even in the general population, but far more commonly in patients with pancreatitis. And if you divide this, there is ones with family history and one without family history of pancreatitis. Now, this hereditary pancreatitis is a rare autosomal dominant disease where there's multiple members in the family who are suffering from pancreatitis, and that's caused by a very specific gene mutation called PRSS1. And the history is quite obvious, but if you take a patient without a family history, very small number of patients will have this PRSS1 gene mutation. But there are other patients who have truly idiopathic pancreatitis, where if you do a genetic test, you'll find a mutation. It is it is causing what looks like apparently sporadic pancreatitis, and that's where we think that the gene and the environment are interacting and causing pancreatitis. And CFTR, which normally causes cystic fibrosis, also is associated with pancreatitis without cystic fibrosis. And the SPINK1 gene SPINK1 is a protein that helps the pancreatic acinar cell mop up any trypsin that gets activated within the cell. And so it's a protective mechanism against auto-digestion of the acinus. And when there is a mutation in this gene, that protective mechanism is lost, and we believe that it can cause pancreatitis. But this mutation is found in 2% of the general population and 40% of pancreatitis patients. So we believe that it is somehow relevant to pancreatitis, but the patients don't give a family history. So we suspect genetic causes of pancreatitis when the patient has when the pancreatitis starts below the age of 35. Nobody has investigated patients by age 50 who have idiopathic pancreatitis, but the general recommendation is below 35, possibly look for genetic mutations. There is no treatment directed at this mutation, so from a therapeutic standpoint, there is nothing that we can do for the patient because they have a mutation, but it helps to stop unnecessary procedures on the patients if they have genetic cause. Drug-induced is fairly frequent to blame drugs for pancreatitis, but it's difficult to prove. There are very few drugs where that re-challenge has been done and the patient has been proven to have pancreatitis repeatedly with exposure to the drug. And usually there's a short latent period between the start of the medication and the pancreatitis. If somebody's on lisinopril for 10 years and gets pancreatitis, you can't blame the lisinopril on it. Same thing with thiazides and many other drugs which are commonly blamed. But if the patient started lisinopril and 3 weeks later gets pancreatitis, maybe that was the cause. So one needs to look at the latent period and then decide whether the drug was. And the list is ever increasing as more and more drugs come on the market. But most drugs, it is a very uncommon event. So let's look at the common misdiagnoses as pancreatitis. Mildly elevated amylase and lipase in the setting of abdominal pain is the most frequent one we see. This is non-specific. If your amylase in the lab is upper limit is 120 and your patient comes with 130, I'm not sure what to do with that information. It's really non-specific. And same thing with the lipase. And if you have abdominal pain, you tend to put the two together and say the patient has pancreatitis, but that's not that straightforward. And I would like to see CT or MR evidence of pancreatitis in this patient before I label them as pancreatitis. There is a condition called macroamylasemia, which needs to be kept in mind. So these patients have a persistently abnormal amylase in the setting of persistently normal lipase. So if the patient comes to me with 20 pairs of amylase and lipase, and all 20 show an abnormal amylase and a normal lipase, that surely should be a macroamylasemia, because that's what happens there is that the amylase gets tagged to an immunoglobulin. And now the molecule becomes too big for the kidney to excrete it, so it hangs around in the body. It doesn't do the patient any harm, but it misleads the physician in thinking the patient has pancreatitis. And if this patient has abdominal pain, the patient will get labeled as pancreatitis. So it does need a special lab test to confirm it, but that's possible to do so. But this should be kept in mind when one of the enzymes is persistently abnormal and the other one is persistently normal, that there's some discrepancy here that should raise the issue of macroamylasemia. Sphincter dysfunction is a favorite diagnosis to make in somebody who has abdominal pain. You don't know why, but more recent studies which have looked at randomized controlled trials of sphincterotomy in patients with abdominal pain have shown basically that this entity doesn't exist. Measurement of sphincter pressures is fraught with technical problems. Almost anybody can get an elevated pressure if you change the catheter from this way or that way. And abnormal motility of the GI tract is common in functional dyspepsia. If you have functional dyspepsia, you're going to have many abnormalities, motility abnormalities in the upper GI tract, like delayed emptying of the stomach. Yesterday I was reading about this, the issue of the decreased ejection fraction of the gallbladder, which is a favorite reason to take out the gallbladder. That disease, biliary dyskinesia, only exists in the United States. Nowhere else in the world does anybody take out the gallbladder based on an ejection fraction abnormality. And so this is the same problem. In functional dyspepsia, you will see abnormalities in the gallbladder, in the stomach, in the sphincter, in the duodenum. These are all epiphenomena. They are not the cause of the patient's symptoms. They are somehow related. It's like IBS. The constipation doesn't mean you should take out the colon. I mean, that's not the answer to constipation. Similarly, people are trying to destroy the sphincter because the pressures are abnormal, but that doesn't solve the problem. So anyway, after thousands of ERCPs and multiple other things being done to the patient, this entity has now been shown to not to exist. So I would not use this as a reason for the patient's pain. It's probably the result of the patient's pain. Another favorite whipping block is pancreas divisum. It just unfortunately is found in 7 to 10% of the population. So if you have pancreas divisum and abdominal pain, the two are put together and the patient is labeled as having pain due to pancreas divisum, and the patient undergoes multiple ERCPs and sphincterotomies. Unfortunately, it can be harmful because if you cut the minor sphincter, minor sphincter is extremely small to start with. You can barely put a pin through the minor papilla, and if you cut it, it scars. And so it's basically the results of sphincterotomy for pain and pancreas divisum have shown that response rates are similar to that of placebo. So it's really not appropriate to cut the sphincter for abdominal pain. And it rarely causes pancreatitis. And there also one should be cautious in labeling pancreas divisum as a cause of pancreatitis. But the patient is having recurrent pancreatitis, true pancreatitis, cutting the sphincter is reasonable. But otherwise, I think that the risks of the sphincterotomy are greater than the benefits of doing it. So another common problem where we see that there's an abnormality and there is pancreatitis and the two are connected and one is blamed for the other. Let's look at chronic pancreatitis now, and the definition is that it's a progressive fibroinflammatory disorder that eventually leads to destruction of the gland, causing exocrine and endocrine failure. Now, all parts of this definition are important because something or the other is found in patients who don't have chronic pancreatitis. So it should be progressive. It is fibrosis and inflammation put together. It eventually leads to destruction of the gland, requiring exocrine and endocrine replacement. And not all diseases, not all conditions where these features are present are actually have chronic pancreatitis. The most common causes are alcohol, genetic abnormalities, and idiopathic. And alcohol is actually now in the 40% range in terms of causing chronic pancreatitis. There are lots of patients where the genetic mutations are found, and probably is the explanation for the chronic pancreatitis. And of course, there's a lot of patients with idiopathic chronic pancreatitis. And another important issue here really is the fact that endoscopic ultrasound is often used to make a diagnosis of chronic pancreatitis. And there's a huge problem here because an abnormal endoscopic ultrasound is not equal to chronic pancreatitis. And what I like to see is patients having clinically acute pancreatitis in a very definitive manner. So if you have abdominal pain and an abnormal EUS, I'm not prepared to call that chronic pancreatitis unless a patient also has proven acute pancreatitis at some time in the history. I have patients with 20 admissions to the hospital with abdominal pain and never had elevation of amylase and lipase, never had CT or MR evidence, and they carry a label of chronic pancreatitis. That's hard because one would expect with 20 admissions, sometime the patient would show evidence of acute pancreatitis. So it's difficult to diagnose without this feature unless there are advanced changes. So if you have calcification or a dilated duct, that's a different matter. In the absence of that, it's hard to make the diagnosis without these features. So there are a number of tests that are used to make a diagnosis of chronic pancreatitis, including CT, MRI, MRCP, endoscopic ultrasound, ERCP, fecal fat, and fecal elastase. And all of these have issues in terms of sensitivity and specificity, and one needs to know how to use the evidence from these to make a diagnosis of chronic pancreatitis. The cardinal features of chronic pancreatitis on a CT scan are calcification, dilated pancreatic duct, and pancreatic atrophy. When you have these, there's absolutely no question the patient has chronic pancreatitis. Unfortunately, these are considered to be advanced features of chronic pancreatitis. And CT negative chronic pancreatitis, that's really the difficult piece, and this is so-called early chronic pancreatitis. And it can be a challenge to diagnose, especially in the absence of clinical acute pancreatitis. So this is a group of patients who often gets a lot of procedures done and is difficult to diagnose. But those who have obvious features on CT, I think that those are much easier to diagnose. So in this world of increasing use of endoscopic ultrasound, and we are getting more and more into this issue of EUS abnormality without pancreatic disease. So the patient has no definitive evidence of pancreatic disease but has an abnormal EUS. EUS is very commonly abnormal in patients without pancreatic disease. There are all kinds of environmental exposures that give you an abnormal EUS, including smoking, alcohol use, obesity, diabetes. And so it's becoming harder and harder to use EUS to make a diagnosis of chronic pancreatitis simply using EUS alone. And it's impossible to interpret without appropriate clinical history. So I would say, patients should meet criteria for pancreatitis that we discussed. And if in that context the patient has an abnormal EUS, one can make a diagnosis of chronic pancreatitis, otherwise it's difficult. A diagnosis of chronic pancreatitis solely based on EUS findings is likely to be inaccurate, unless there is advanced disease in these patients. So another common test that is ordered these days, increasingly being ordered these days, is serum IgG4. And we looked at Mayo's, I think 3 or 4 year data, and there were 6,000 IgG4s measured. So clearly something that's being overused. And they're probably being measured for various reasons, but it can be misleading if you order it without a proper clinical context. And the positive predictive value is 10%, and so it's basically used to define IgG4 related disease, but IgG4 related disease is not very common. It's very rare. And IgG4 elevations are far more common. In fact, when we looked at our 6,000 patients, 5% had an elevated IgG4, which is the baseline prevalence of an abnormal IgG4. So if you order an IgG4 without clinical context, you're going to be faced with a false positive diagnosis. So do not order if clinical presentation not suggestive of IgG4-related disease. Pancreatic steatorrhea is another thing where there's common issues in terms of both diagnosis and treatment. Pancreatic steatorrhea occurs only after loss of 90% of pancreatic function. And at that point, the pancreatic disease is not subtle. So if you have a normal CT, you don't have pancreatic steatorrhea. So by the time the patient has pancreatic steatorrhea, the disease is fairly obvious on CT. And if you have any doubt about the diagnosis, it's better to get a fecal fat, 48-hour fecal fat, than put the patient on enzymes, because the enzymes are pretty expensive and they need to be taken lifelong, because once you have pancreatic steatorrhea, it's not reversible. So I prefer, whenever I have a doubt about the diagnosis, to get a 48-hour fecal fat on 100 grams of fat diet, and that is basically definitive in terms of diagnosis. And then if the patient needs enzymes, then it's appropriate to use that. But what has been commonly used in replacement for fecal fat is fecal elastase. And fecal elastase is very easy to order, but it's also frequently false positive in the general population. And the abnormal fecal elastase has been equated to pancreatic insufficiency, which is a big leap of faith, because you could have an abnormal test, but it doesn't mean the patient has pancreatic insufficiency requiring enzymes. And in many studies, 10% of controls have had an abnormal fecal elastase. So if you use this as a test for pancreatic steatorrhea, you'll often be misled. The other problem is that it's often used in the setting of diarrhea. So you have a patient with diarrhea and you want to know if it's pancreatic in origin, you order a fecal elastase. Well, that's where the highest false positive rates are. It's diluted in a watery stool, and you get a false positive fecal elastase. So it's a problematic to use this alone to diagnose pancreatic steatorrhea, and unfortunately it's very easy to order, and once you have the test results, you end up putting the patient on enzymes when they don't need it. So to me, this is problematic to use it in the absence of a clinical setting in which the diagnosis will be correct. So we at Mayo have a new test for workup of diarrhea, which combines fecal bile acid and fecal fat. Many of our patients have already lost their gallbladder because somewhere along the way somebody has removed the gallbladder for abdominal pain or for low ejection fraction or whatever, and now they have diarrhea. And the question is it pancreatic, is it biliary? And so a 48-hour stool collection of 100 grams of fat diet at Mayo, you can do both a bile acid assessment and fecal fat assessment. And in bile acid-induced diarrhea, you'll see a high proportion of bile acids in the stool, and that can be treated with bile acid binding agent, and pancreatic steatorrhea can be treated with enzymes. So this helps both diagnose both bile acid-induced diarrhea and steatorrhea. One must remember that if you just have plain diarrhea, small bowel diarrhea, you can get up to 15 grams of fat in the stool. There have been studies where people have been given Go Lightly and their fecal fat measured, and you can get 15 grams of fat in the stool simply from having intestinal hurry. So 10, 12 grams of fat in the stool is not pancreatic steatorrhea. So again, interpretation in the right setting is important. And generally, when you have pancreatic insufficiency, the fecal fat is more than 20 grams a day. So if you have 10, 12 grams, you have to doubt whether the patient has pancreatic insufficiency. And another common practice is to have all patients with pancreatitis go on pancreatic enzymes when they leave the hospital. The idea is that you want to rest the pancreas. Well, there's no data to show that you can rest the pancreas by taking pancreatic enzymes. The body responds to food even by thinking about it. So the cephalic phase of pancreatic, there is a cephalic phase even for pancreatic digestion. So there's no way you can rest the pancreas by taking enzymes. So to me, this idea of putting everybody who's got acute pancreatitis on pancreatic enzymes is not scientifically correct, because it's not going to help the patient with resting the pancreas. And these are the places where it does not help. And I tell the companies that make enzymes that your product is more often misused than correctly used. And these are the various places where it's not helpful. It is not helpful to prevent another attack of pancreatitis. It is not helpful to rest the pancreas. And to treat abnormal fecal elastase without steatorrhea is not going to help the patient. To empirically treat, I've had patients with IBS who have been treated with enzymes, and they have a placebo response to enzymes and they swear by it, but they have absolutely no pancreatic disease. And to treat abdominal pain of presumed pancreatic origin with enzymes is also not helpful. It's just you're basically giving them a placebo. And in IBS, you're giving them an expensive antidiarrheal. Okay, well, we'll talk briefly about pancreatic cancer. I'm covering a lot of topics, and I'm hoping that I'll open it up for discussion so you can have more questions about specific questions you may have about the disease. Pancreatic cancer is the fourth leading cause of cancer-related death in the United States. It's of the major cancers, pancreatic cancer has the lowest 5-year survival rate. And if you look at the 5-year relative survival of pancreatic cancer, it's 6.7%. It's 90% for breast cancer. It is 67% for colon cancer, colorectal cancer, and 100% for prostate cancer. So pancreatic cancer has a miserable outcome even today. And it's one of the few cancers for which survival has not improved substantially in more than 40 years. And there's worse to come. It appears that the other cancers are getting better, while pancreatic cancer incidence and mortality is increasing and will continue to increase. It is predicted that as early as 2020 and surely by 2030, pancreatic cancer will become the #2 cause of cancer death in the United States, as breast and colorectal cancer go down in their mortality and pancreatic cancer goes up. So this is something that is going to be on us pretty soon in terms of being a common diagnosis to make, and the high mortality makes it imperative that we do something about it. So why is the mortality so high? The disease is diagnosed at a late stage. 85% are unresectable at the time of diagnosis, and only 8% are confined to the pancreas at diagnosis. And from the onset of symptoms to death is only 6 to 8 months. So it's not only a late presenter, but also an aggressive progression of the disease. And unfortunately, even complete resection of the cancer is not curative, and patients live about 20 months after surgery. So the surgery is still palliative and not curative. And part of the problem is that chemoradiation is ineffective. It palliates, rarely cures. So there are various multiple challenges to making a difference in pancreatic cancer, and a lot of research is going into it. But at this point, it appears to be a fairly recalcitrant cancer, which is both hard to diagnose early and hard to treat. Our approach to diagnosis of pancreatic cancer is to do a pancreas protocol CT, and that basically classifies the patient as being resectable, unresectable, or borderline. And in patients, in most centers, you would do a biopsy in all of these conditions. We take patients who have got clearly resectable tumors to surgery, but it won't be unreasonable to confirm the diagnosis. But the unresectable and the borderline needs biopsy proof because they need to go through chemotherapy before anything else is done. Bile duct stenting is done in jaundice patients if surgery is going to be delayed in resectable disease, or if they're clearly going through chemotherapy, either due to advanced disease or because of neoadjuvant therapy. So stenting is reasonable in that setting. We often see patients who are getting a CT, an MRI, and a PET scan within 24 hours of each other. These don't add very much to each other. So multiple studies are not going to make a difference here. The pancreas protocol CT should be good enough to make a very good assessment of the stage of the disease. And EUS obviously allows us to biopsy the organ. So in clearly resectable fit patients who have a low CA19-9, surgery followed by chemo is reasonable first approach. And I put all three here because there is anatomic resectability and there is a physiologic patient's physiology of able to handling the surgery. And then there's a biologic aggressiveness for which we take CA19-9 as a surrogate. And all three of them pointing in the right direction, then surgery first is reasonable. In clearly unresectable stage 4 disease, the patient is going to get palliative chemotherapy. But if the patient is borderline, that those who are not clearly resectable or unresectable are called borderline. And borderline is defined as something that can technically be resected, but the results of the surgery are not better than doing nothing because there is still disease left behind. And in those patients, neoadjuvant therapy or treating with chemotherapy before surgery is the best way to go forward. And then you restage the cancer after the chemotherapy. And if at that time the patient is still resectable, then you go ahead and remove the cancer. And therefore, this is our current approach to managing pancreatic cancer is being able to classify them in these three categories and then proceeding further based on which category they fall into. There have been recent advances in chemotherapy. And these are the options that are available for chemotherapy in decreasing order of effectiveness and toxicity. Unfortunately, effectiveness and toxicity go together. So the most effective chemotherapies are also the most toxic. FOLFIRINOX is a combination chemotherapy which has improved 1-year survival of pancreatic cancer from a miserable 10-15% to over 50%. And it still remains the best treatment option for pancreatic cancer. But it needs a patient who is clearly fit to be able to undergo it because it's also toxic. Removing the irinotecan or making it FOLFOX does improve the toxicity, but is slightly less effective than FOLFIRINOX. There's another new drug on the market called Abraxane, which when combined with gemcitabine gives comparable results to the above regimens. Gemcitabine alone is the one we use for patients who cannot tolerate FOLFIRINOX or Abraxane, and its results are somewhere in the 15% 1-year survival rate. So that's what we had for the last 10, 15 years. Well, move on to another topic which is fairly common in terms of referral to the pancreas clinic, and that's the cystic lesions of the pancreas. And these are fairly common incidental findings on CT scans. Now, CT and MRs are done for quite a wide variety of reasons, and you end up picking up these incidental lesions. And depending on the age, they can be found in up to 20% of patients who are undergoing a CT or MR. And majority of them are benign, what are called side branch IPMNs. IPMNs are like polyps of the pancreas. They are adenomas which have a potential to turn into cancer. But unlike the colon, we don't have a colonoscope to remove them, so we end up watching them. And because removing these polyps of the pancreas requires removal of part of the pancreas, it's like trying to do a colectomy for a colon polyp, a 2 millimeter colon polyp. So we end up following them. And as we follow them, we realize that majority of them will do the patient no harm. So it is a reasonable approach to following them, but they're very common, and therefore one realizes that one has to somehow risk stratify them, otherwise we'll spend a lot of healthcare dollars following these cysts, which may do the patient no harm. So these are the various cysts that can be seen in the pancreas. You don't need to know all of them, but it just tells you what a wide variety of cysts there can be in the pancreas. And you need to be able to make a reasonable conclusion based on CT or MR as to which of these cysts the patient is most likely to have. And then you follow them based on what the cyst might be. The most important piece that is that these patients who have got a solid tumor which became cystic, these need to be removed mostly. So, but this is the IPMNs that we are talking about, which are the most common among all of these in terms of the type of cysts we see, and these for the most part can be followed. But again, one needs to know what type of cyst it is and be able to make a reasonable judgment about whether this can be followed safely or needs to be removed. So this is what's called a mucinous cystic neoplasm, and it's found exclusively in women and exclusively in the body and tail of the pancreas. And it has an ovarian stroma. This is clearly a disease of women, and occurs in middle-aged women. It's not very common, but if you see it, we generally take it out, though it can also be followed for at least for some time. This, on the other hand, is what's the IPMN that we talked about, the intraductal papillary mucinous neoplasm, comes in two flavors. One involves the main duct, and one involves a side branch of the pancreatic duct. And when it involves the main duct, it often pours out mucin, and this can be seen from the ampulla of mucin pouring out. And this is another picture of mucin coming out of the ampulla. When you see this, the patient has main duct IPMN, and this needs to be resected as the chance of having cancer is very high, and we would not generally follow these patients. But then there are patients who have this incidental cyst in the pancreas, and these unfortunately are very common, and I'll show you more of these. You can see these, and this is mucin inside it. So this is fairly, not usually don't see this many cysts, but having one or two cysts in the pancreas is fairly common. In fact, there has been studies to show that radiologists often don't call it because they see it so commonly. And some of these are pinhead-sized cysts, so they're pretty small. These, unfortunately, are very common and need some kind of risk stratification because majority of these patients will come to no harm from the cysts. This is another one. This is fairly small, but looks magnified on this ERCP. But these cysts communicate with the pancreatic duct, and as I said, these are very benign and take a long time to turn into cancer, and we have an opportunity to intervene if necessary. So in patients with there are multiple guidelines with different recommendations for how to follow this, and to some extent, almost needs to see a specialist at least once to make sure we're doing the right thing for the patient. This is a moving target. As more data comes in, we're going to have continuing changes to the guidelines. But immediate surgery is recommended for patients who have jaundice, patients who have a clear mass, or whose main duct is more than 10 millimeters in size. And further investigations are warranted in patients who present with pancreatitis, where the main duct is between 6 and 9 millimeters, or who have an intramural nodule which is not enhancing, or the cyst size is more than 3 centimeters. These patients need further investigations and then close follow-up. And the rest of the patients who don't meet this criteria, which actually is the majority, you can follow them at 2 to 3 year intervals because they are unlikely to come to harm in the shorter term. And majority of the patients will fall into the category of not having any of these risk factors. And so majority of them can be followed quite safely. Finally, I'll talk about a rare disease which is very commonly looked for, and this can be a problem. If you look at 100 patients with obstructive jaundice, which looks like pancreatic cancer, only 2 to 3% will have this disease. And if you look at 100 patients with pancreatitis, maybe 2 will have this disease. But often IgG4 is measured to try and see if you can make a correlation. But IgG4 does not make the diagnosis, and therefore measuring IgG4 in this setting is insufficient to make the diagnosis. To put it in context, about 10% of pancreatic cancer patients will have an elevated IgG4. So you ought to be careful about using just this test to make the diagnosis. But again, autoimmune pancreatitis is the only pancreatic disease which gives you the satisfaction of a medical treatment. And therefore there is a great enthusiasm to make this diagnosis. But it's a rare disease, and so most patients in whom you suspect it will not have it. This is a typical picture. You can see how closely it mimics pancreatic cancer and why the patient is dramatically relieved when they're told they don't have pancreatic cancer. The 67-year-old man who has a 2-week history of obstructive jaundice, 30-pound weight loss, and new-onset diabetes, and you can see his CA19-9 is markedly elevated. And this is his pancreas diffusely enlarged. And yet this patient does not have pancreatic cancer, yet autoimmune pancreatitis. So it is attractive to make the diagnosis, but it's not common. And this is another example of a patient with autoimmune pancreatitis, diffusely enlarged pancreas. There's also this rim-like enhancement around the aorta, which is retroperitoneal fibrosis. And in this patient, you can make the diagnosis simply based on this combination, but again, not common. This is another feature of autoimmune pancreatitis which is fairly common, which is this rim-like enhancement around the pancreas. And again, if you find this, your diagnosis is pretty correct. One of the most common misdiagnoses is looking at a plump pancreas in a young woman and calling it autoimmune pancreatitis. The pancreas in autoimmune pancreatitis has a delayed enhancement. That is, during the arterial phase, it doesn't enhance very well. In the venous phase, it looks brighter than in the arterial phase, which is a reverse of what would normally happen. A normal pancreas will enhance normally. It'll enhance in the arterial phase and fade in the venous phase. So the most common misdiagnosis we see is of young patients who have a normal pancreas where a diagnosis of autoimmune pancreatitis is made because the pancreas looks big, but it enhances normally, and that's not autoimmune pancreatitis. So again, all of these diagnoses have their pitfalls in how you make the diagnosis, and you need somebody who is familiar with the disease to make the diagnosis. And so briefly, we have overviewed a number of common pancreatic diseases and common misdiagnoses and a brief approach to management. I'm happy to take any questions about any of the conditions or some things that I did not mention in my talk. Thank you.
I'm sorry. I'll go back. Go ahead.
Let me ask you, you say 85% of pancreatic carcinomas are unresectable. Of the ones that go to surgery, how many of those turn out to be beyond unresectable? Really?
Good question. So in today's world of pancreas protocol CT, we call it futile laparotomies. Futile laparotomies have dramatically decreased in number from the days when we used to have the old CT. So I've asked the surgeon this question, and it's probably down to 5% or less. So by the time we're done with the workup and send the patient to surgery, very few are opened and closed because the disease is advanced. But that 15% who go to surgery are not necessarily early disease. They're resectable, but the survival is still only 20 months or 25 months. So it is resectable, and the right surgery is done, but it doesn't equate into cure. Of the patients who go to surgery, 20% survive 5 years. So for the vast majority, it is palliative. But the futile operation is a patient who has got a liver met or a mental mets and things which are clearly not resectable. That has decreased dramatically with more advanced imaging.
I wondered if you had any speculation as to why the incidence of pancreatic cancer is surging so much. It looked like from 2010 to now, it was a dramatic increase.
Good question. I had a slide on that, but I can tell you. So we think that one is it's an age-related cancer. The population of America is aging, and as it ages, there are going to be more patients with pancreatic cancer. Obesity or epidemic is contributing. For every increase in BMI, there is an increase in pancreatic cancer incidence, and it probably accounts for 20% of the pancreatic cancer rise in incidence. But despite these two, these two factors don't completely explain the increasing incidence. There are probably other environmental factors which we don't completely understand, which probably are contributing to pancreatic cancer. But it doesn't help that the BMI of the American population is rising. It's going to have a lot of consequences, including pancreatic cancer.
What has been your experience, and is there any role for a secretin-stimulated MRCP for the diagnosis of chronic pancreatitis?
Good question. So secretin-stimulated MRCP. So there are some centers which use it far more than we do. We have one of my colleagues has an interest in secretin-stimulated endoscopic ultrasound. He does an endoscopic ultrasound and gives secretin and looks at the dilatation of the pancreatic duct right then and there. I don't think he or the secretin MRCP people have given me sufficient guidance as to what to do for the patient based on the results of the secretin test. So, for example, in patients with pancreatic disease and pancreatitis, if you want to use a secretin test to determine whether the patient should get a sphincterotomy, it's been disappointing to look at that result and decide whether that's useful. Delineation of the side branches may be better with secretin MRCP. So, I haven't used it extensively in my practice because whenever I've done it, it hasn't helped me. But we do use secretin in the endoscopic ultrasound area in research settings to collect pancreatic juice, and from that we're learning a lot about what secretin is doing to the pancreas and how the transient dilatation of the pancreatic duct can be used to make a diagnosis. But at least in my practice, I don't use it extensively. Okay. Okay.